Which one is yours?
Sepsis Green?
Sepsis 3.
Oh, just kidding.
Okay. Most hospitals are still not using it. And so it's actually still JAMA is recommending it. I'm not sure why the implementation is so slow, but it is the most current research that's out there. So we went through that as well. He just told you all of these things, channel experts, and it's the Sepsis 3 campaign. You saw that SIRS and severe sepsis went away, but I know that a lot of hospitals are still using those terminologies, even though it's not. He talked about the Q-SOFA here and how you have the 3, you have to have 2 of the 3 and a suspected infection. So it can't be 2 of the 3 and not suspected infection, but 2 of the 3 as well. Sometimes it's referred to as HAT, hypotension, altered mental status, and tachypnea. So sometimes people remember it better. It's the same thing. These are the Q-SOFA things, but in another form that it might be easier to remember as well. So this is the JAMA algorithm that he talked about here. If you have, if you have more than 2 in a suspected infection, and assess for organ dysfunction. If you have organ dysfunction and sepsis, you have a high lactate, and you need vasopressors, and you have septic shock. So it's pretty straightforward in how they looked at that as well. You don't need to memorize all of this. This is just explaining the latest what's going on with that as well. We're going to skip through this as well. We're going to skip that as well. So in septic shock, and we've talked about in hemodynamics, you have this bounding cardiac output. So higher than any other cardiac output, you will see you put a cardiac output monitor on somebody, and they have sepsis. They have cardiac outputs of 10, 12, 14, ridiculously high. And you won't see it in any other type of patient as well. And they'll have a really low blood pressure, really low SVR. Like they have crazy low blood pressures, and you've probably already seen that as well. Low SVR, EF is down as well. They have multiple organ failure. You know all of this. This is not new. Skin, all these things, these are signs and symptoms you should be very familiar with. I'm not going to go over it. It's very, very common, and it makes sense what they have. In septic shock, at the beginning, you can have a lower white count, but then you're going to have an increase. Because it's infection related, you will have a shift to the left or an increase in bands, because those are the neutrophils that are your first responders that are coming out to try to fight that infection. So you will have a shift to the left. The hyperglycemia is from that epinephrine release as well. Acidosis, that's because of the anaerobic metabolism, which also gives you the lactic acidosis as well. Here's an interesting fact that you need to put in your mind for the rest of your life. People who have sepsis will have a bacteria in their bloodstream, but only 45% of the time will you pick it up, because when you draw blood cultures, it's hit or miss if you're going to really grow the organism or not. But if it looks like a duck and it walks like a duck and it quacks like a duck, then it's a duck. So if they have a high white count and they have a known UTI and they have severe hypotension that you can't get them off the pressors for, they're a septic patient, your blood cultures are negative. So I still have students telling me, like in 331 all the time, but they don't have an infection in their bloodstream. And I'm like, well, they probably do, because we only pick it up 45% of the time. So something good to remember. So what do we do? Identify the source and treat it. Get used to two. You should in your career get used to knowing, and it's not going to be tested in this class, but drugs will be commonly used for different sites in the body, and you'll be seeing that and knowing that as well. Very commonly, gram-negative bacteria is the most common sepsis organism that we see as well. We intubate them if we need to. All of this makes sense. If they need inotropes, we're going to give them inotrope. Nobody uses isoprel anymore. And then immunotherapy as well, and nutritional support. And just as I talked about this already, but there's a big study going on called the Merrick study, where we're giving them vitamin C steroids and thiamine, and they've got thousands of people in these studies right now, and they're having incredible success. So kind of interesting. What are we changing? Okay, several years ago, this drug came out called Zybris. It's also called Droteg, DROTRC, colchicine alpha. This is what and then everybody who was septic got this drug. And then the reason I put this slide on there, because this is still in your book. And then it got taken off the market because the blood clotting problem, the bleeding problem was so bad it was killing patients. So the only reason I include this is that if you're gonna talk about a sepsis patient, please don't include Xigris as a possible treatment. It's in your book. Know that that's not current, and we don't use this drug anymore as well. All right, we're almost done. DIC. It's not a disease process, it's a secondary process, and it is unique because you have bleeding and blood clotting at the same time. We call this consumption coagulopathy. You're putting out so many factors that are throwing these little baby clots in the body that when you need the clots, like we draw blood from you, you just bleed and bleed and bleed from it. You bleed from your gums, and you bleed out of your fold, and you bleed from your nose, and you bleed out of your, around your mouth as well. They bleed in their ET tubes as well. And so we have damaged microvascular that leads to organ dysfunction. So what this means is that, I'm gonna show you some pictures in a minute. I'm gonna come back to this. But we have like these all these are blood clots on somebody's, this is all DIC. The same thing's happening on every organ in your body, and your lungs, and your liver, and your kidneys, and your GI tract, and your brain. So you're throwing these microvascular clots, and you're losing tissue all over the body. DIC patients are very, 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 very sick patients. Okay. Here we go. Consumption coagulopathy. Clotting factors are used up, and the liver can't replace them. Clots form in response to the thrombogenic stimulus. All those cytokines that we talked about, like bradykinin and serotonin that cause platelet aggregation, are stimulating these clots in the microvasculature, and then we don't have enough thrombin to replace them, and so then we're bleeding from everywhere. All types of shock can lead to DIC, but gram-negative sepsis is the worst because of the endotoxin release in these patients. And you have, we already kind of talked about that. So they bleed from everywhere. They bleed from IV sites, they bleed from ABG, when you test an ABG as well. They've got the petechiae, the ecchymosis, and the necrosis. Nose, hands, and feet tend to be a real hot spot. I always look at the bottom of my patient's feet. Even now with students, I'm always looking at the bottom of their feet to see if they have little dots, little ink dots on there. They're not ink, but they look like ink dots to me, of what's happening as well. You can watch this later. So what happens with these patients is that they're bleeding from everywhere, but they're also throwing all these clots. So we give them heparin. So you have a patient and you're gonna make them bleed more, and they are bleeding. And patients, I've had patients that have such bad DIC that we're putting like gauze in their nose, and we're trying, and they're just bleeding from everywhere. It's just horrible. And then you're telling the family, yes, we're giving them this drug to make them bleed more, and that's very hard to grasp the mind around. But then if you explain, I always show them the clots, because there's always evidence of clots on their body. I show them that, and I say, well, this is what's happening in his heart, and in his brain, and in his lungs, and in his kidneys, and this is what we're trying to prevent. So you create more bleeding, and you end up having to give more blood, but hopefully you're stopping those microvascular clots that are killing all of your organs, which is the big problem as well. So these people are going to have really high PTINRs and APTTs, which are your thrombin, which is showing that you're bleeding because you don't have clotting factors. Your platelets are low, your fibrinogen is low, your H&H is generally low from the bleeding as well. We're not going to do a case study. This is not an uncommon thing. So she had enough, she's going to lose most of that nose there. She's got a few here.